A very good evening. My name is Tee. I'm an UpperGI surgeon currently working in IKN. Thanks for joining us today for the third series of UpperGI Virtual Grand Round. For those who join us for the second or third time, thanks for spending time with us again. And for those who join us for the first time, this is a collaborations event by MUGIS, Malaysian UpperGI Surgery Society, some of the Ministry of Health, Ministry of Education Hospital, and our industrial sponsors. So for last week participants, we have up to about 500 who registered, almost about 300 who signed in, and welcome our participants from the neighboring country, Singapore, Brunei, China, India, Bali, and even Yemen and Ecuador. So for this talk, the first 20 minutes will be given to the speaker and subsequently followed by a 10-minute slot for the sponsor. Today, our sponsor is LabTech and Panther Healthcare. They will share a video of their products with us. And lastly, we will have our Q&A session. For all the participants, please kindly type in your questions in the Q&A box, and we will try to answer most or all of the questions. And since last week, we see that there are two moderators, and these are the changes that we have made based on the attendee feedback. Hopefully, we will have more broader discussions and for the given topic. So today, I have my co-moderator, Dr. Lim Hui Cheen. He's an upper GI consultant currently working in Regency Specialist Hospital. And I have the pleasure to work with him before in Hospital Sungai Buloh. Mr. Lim Hui Cheen, do you want to have a word with the participant?
I welcome everyone to this actually third upper GI surgery virtual grand round. So we hope actually with all your participation, make this actually event actually much better event.
Yeah. So I think without further delay, I will actually invite Mr. Sou Jing Kim. He's our second-year trainee in upper GI subspecialty, and he obtained his Master of Surgery in UKM. He worked in Hospital Pulau Pinang and also Hospital Ipoh before. Mr. Sou Jing Kim, I'll pass the camera to you.
Hi, good evening, everyone. Thanks, Steve, for the kind introduction. Without further ado, I will start on my slides. Today, my topic will be gastritis, the common Malaysian stomach flu. But don't worry, it's actually nothing about the flu. It's basically mainly on gastritis. Now, first of all, I have no disclaimer, I have no disclosures, I have no conflict of interest. But later, we are sponsored by Panther, which have 10 minutes of presentation. Now, the topics that I will talk about basically is about gastritis, diagnosing gastritis, the definitions and classifications, and also differential diagnosis and the role of GI lab. Now, further than that, we will talk about adverse clinical effects of prolonged PPI usage and what are the evidences, a bit of treatment summary and references. This topic is mainly about gastritis per se because it is a medical condition and sometimes it is commonly misdiagnosed. That is the issue where we are dealing with, and it has often led to prolonged PPI usage. Like what Mr. Kelvin said last week, it is more like PPI is by being prescribed like water. Now, diagnosing gastritis, most of patients in our clinics, and even at the district level, in the GP clinics, they present with upper abdominal pain or discomfort. Now, the symptoms are commonly misdiagnosed as gastritis. Gastritis rarely causes any symptoms per se. More uncommon that leads to abdominal pain. When patient presents with abdominal pain, there are various causes. But if it's want to relate it to release the stomach, let's say, if we call it functional abdominal pain, it's due to hypersensitivity of pain receptors in the stomach or abnormal spasm of the stomach musculature. Now, this is nothing related to gastritis. Now, other conditions can be stress-related or due to irritable bowel syndrome. Now, come to the topic of gastritis per se. Gastritis is derived from the Latin words, which means inflammation of the stomach. There are various causative factors. and diagnosis requires endoscopic assessment and proper histological confirmation, not just purely on clinical diagnosis. Now, lab testing imaging studies are unable to prove a diagnosis of gastritis, as we need to treat the underlying cause. And later, I'll talk more about the importance of GI lab, which we mainly it helps out to rule out functional esophageal causes and motility disorders of the GI tract, which mainly involves manometric studies and 24-hour pH studies with or without pH impedance. Now, why we talk about diagnosing patients with gastritis, we want to avoid the phenomenon of labeling, because once patients are labeled with gastritis, they go around with this diagnosis, and it's very difficult. It's just like a stigmata to them. Very difficult to change the mindset. Now, the phenomenon of diagnosing patients with gastritis without evidence is called labeling. Now, this labeling of patient with gastritis can have various negative effects, like delay in diagnosis, and then increased anxiety and incorrect therapy. So with that, I would bring us to more of, you talk about differential diagnosis. When any epigastric pain, we do clinical examination and take proper history. We want to rule out other causes. Some may be related to the stomach, and like functional disorders. Others like reflux disease, gastroesophageal reflux disease, non-erosive reflux disease, peptic ulcer disease, hiatal hernia, and more so if malignancy related to the upper GI, like stomach or the gastric cancers. Now, often than not, in the growing evidence of obesity and related cases, we want to also rule out other pathologies from the liver or the pancreas or the gallbladder. Liver-related, what I put here is for NASH, alcoholic steatohepatitis is gaining importance and is obesity-related. Now, this is just a rapid explanation for our participants and our young doctors out there that do not always label epigastric pain or epigastric discomfort as gastritis. And this will leading to a prolonged usage of PPIs, because we want to avoid stigmata. So we have to think of other causes, like maybe pancreatic causes, maybe liver-related causes, or even gallbladder diseases. All right. Now, next definition, I'll move on to definition of gastritis. Definition of gastritis is basically inflammation of the gastric mucosa. This is, I quote, Rupp and Sugano et al., 2020 gastritis update. Now, basically, it talks about inflammation of the gastric mucosa. On endoscopy, various studies have showed that the gold standard of diagnosing gastritis is by endoscopy, and it shows reddening or edema of the gastric mucosa. But neither of this reddening or edema is specific. Therefore, diagnosis actually requires histological confirmation. And the underlying, we need to identify the underlying causes that led to this gastritis. So again, gastritis, move on to classification and causes. The classification are acute, chronic gastritis, and also atrophic gastritis. Other causes like autoimmune, which are rarer entities. And causes can be divided into environmental and host-related. Now, this is a slide just to share about the environmental causes. Basically, this divided into transmissible and non-transmissible. Non-transmissible are our chemical disorders like endogenous bowel, even alcohol, NSAIDs injections, and physical will be radiation. Transmissible, the most common organism will be Helicobacter pylori, but not forgetting other various causative factors like Mycobacterium, even virus or fungal infection can cause gastritis. Now, host-related per se, what I mentioned just now, autoimmune or immune-mediated is allergic, lymphocytic, eosinophilic, or collagenous, and other causes associated with the systemic diseases like Crohn's, vasculitis, sarcoidosis. But this is more common in the Western population. Now, I mentioned about role of GI lab. This is of great importance, whereby we want to make the general public and all the listeners out there to know that the importance of GI lab, because it helps us because when you diagnose esophageal motility disorders, there's only way is that you have to do a manometry to see the contractility of the esophagus with impedance. And also we do a 24-hour pH monitoring, as depicted on the page before, whereby we correlate the patient's symptoms to a device within the 24-hour period. And we can directly rule out whether the pH is, whether the patient's symptoms is related to reflux. And this was further help us to actually differentiate, basically, is it a physical reflux or a pathological reflux? And we can convincingly tell our patients that it is not gastritis. You are having other symptoms related to the stomach after ruling out other causes. Now, again, and this is a summary. Endoscopy visualizes. Endoscopy will help us visualize the structural abnormality of a fasted upper GI tract. Manometry provides functional assessment, and pH studies will diagnose reflux disease. Now, what is the whole the topic about this presentation is basically we want to highlight the prolonged usage of chronic PPIs. So chronic PPIs do have a lot of adverse effects if prescribed in the long term, as quoted in this paper, Savarino et al. Latest insights to sustain a proton pump inhibitor 2020. Now, this paper, it basically talks about the various side effects, adverse side effects of PPIs, and this slide shows the cohort of the studies that some are prospective, mostly are cohort and observational studies, but they are not randomized control trials. And you can see here over the right hand side, the 5 highlighted in right, those are the more common effects of that which I will discuss later, mainly Clostridium difficile enteric infections and kidney disease. And later on, I'll talk about nutritional deficiencies, also gastric cancer. Those are the later ones which are not so, the evidence are not so strong. Now we'll go through the evidences one by one. Again, this picture also depicts that the gastric fundal polyps and enteral infections, Clostridium difficile infections, and kidney disease, these are higher risk occurrence, and they got higher evidence to show that there's a positive biological correlation, whereby on the right, you can see that there are these PPIs causing bone fractures, PPI causing pneumonia, and these as gastric cancers, they are the lower risk at the lower risk end. Now, to understand the adverse effects, there are many. Basically, the adverse effects classified into adverse effects related to acid inhibition and adverse effects that are not related to acid inhibition. This I quote from Kinoshita et al. 2018. Advantages and disadvantages of long-term PPI usage. Now, again, the adverse effects unrelated are mainly systemic diseases like acute intestinal nephritis, chronic kidney disease, adverse drug reactions, cerebrovascular issues, and ischemic cardiac related issues. As for the more related to our field, we will talk about adverse events related to acid inhibitions, pneumonia, gastric infections, gastric carcinoid, and small bowel intestinal overgrowth, and vitamin deficiencies. I would like to highlight here iron, bone fracture, vitamin B12, and hypomagnesemia. Talking so much about the adverse effects of prolonged use, but do we actually prescribe long-term PPIs? Yes, we actually prescribe long-term PPIs, but we have to know the indication. The take-home message, we need to know the long-term usage, like use it for in Barrett's esophagus or esophageal stricture dilatation, severe esophagitis complicated with past strictures, ulcers with hemorrhage, and even previous history of peptic ulcer, depending on the condition. And cases like rarer cases like Bollinger-Ellison syndrome. This I quote from NICE guidelines. nice clinical guidelines for respiratory disease. Now, moving on to what are the evidences? If we say something is bad, what are the evidences? PPIs and Clostridium difficile associated diarrhea, what are the evidences? Basically, the PPIs, the biological cause, that the postulation is that PPIs reduce gastric acidity and this further alters gut microbiome or gut dysbiosis, and as a result, it promotes Clostridium difficile infection by reducing competitive feed inhibition. Now, these evidences are from meta-analysis and systemic reviews. They are shown to have 2 to 3-fold increase in risk of nosocomial or community-acquired Clostridium infection. Other meta-analysis will show, I put a paper here by Koch and Arthur et al. It involves 42 observational studies, but the incidence that they correlate just shows a mere odd ratio of 1.7. So it's not really very high evidence. And the US FDA actually issued a warning letter regarding the risk of disease in receiving therapy and use of PPI for the dose for the shortest duration of treatment. Next, I'll move on to PPIs and nephrotoxicity. For PPIs, most of the studies have shown that it may lead to acute interstitial nephritis. Then that can be humoral or cell-mediated. But larger core studies now will say that even it has a certain predisposition to leading to chronic kidney disease. However, the evidences are very low, maybe an odds ratio of 1 to 1.5. Now, as for PPI and nutritional deficiencies, each and every one of it has its explanation for it. But like vitamin B12 deficiency is because of reduced absorption in the stomach, and then iron deficiency anemia related to hypochlorhydria and both the hypocalcemia and hypomagnesemia. Now, PPI-induced hypochlorhydria interferes with these absorptions of these various vitamins. Now, of all these vitamin B12 deficiency, hypocalcemia and hypomagnesemia, the most important one is occurs more commonly is hypomagnesemia. Again, the evidences are low. Now, what is more important to us is PPIs given for long duration, can it cause gastric cancer? What are the evidences? Again, the biological possibility explains that hypergastrinemia causes trophic effect on pozytic cells, and this further leads to enterochromatin cells hypertrophy and in activity leading to a possible increased risk of carcinoid tumor. But this few case reports, no randomized control trials, and no causative link. These are the evidences are low. But I found a paper, Chong et al. 2018 reported 2.4-fold risk in developing cancer. Now, this is the paper. In this paper, they study about a cohort of 73,000 patients, which they have treated with H. pylori eradication, and they followed the patient up for a mean of 7.7 years. And they found that the risk is 2.4 risk increase in patients with H. pylori, treated with H. pylori, but patients given PPI for prolonged duration can have a 2.4-fold risk in developing gastric cancer. Now, other smaller associations are PPIs causing bone fractures. Again, these are very low associations, and PPI causing community-acquired pneumonia, and PPI also causes reduced efficacy of clopidogrel. All these studies have shown that they are possible. They have possible biological possibility, but again, the evidences are not strong. Now, are PPIs all that safe? Having talked spoken so much about the key PPI, the various adverse effects. Are PPIs really all that safe? We a word of about false alarm, about making false alarm to broad conclusions, because again, the evidences, we should know the adverse and be aware of the adverse effects, but due to some quality of the study and some retrospective cohorts, we cannot make a full conclusion that even PPI is not. The message is that is important here, right here, is that there should be a balance of therapeutic usage, and more so at the therapeutic duration. We should not just prescribe PPI for various for prolonged duration, and any prolonged usage should be justified. Now, I would end my slide with a brief diagnosis about, a brief about the treatment of gastritis. Now, gastritis, we'll talk about treating the underlying causes. In the treatment, we'll talk about how do we treat the underlying causes, and how long should you treat gastritis. Basically, we treat it for a mean duration of 2 weeks, and we avoid prolonged treatment of more than 4 weeks to 6 weeks. Depends, and we have to review the indication and the clinical findings of, the outcome of the patient. And we review PPI usage, avoid chronic use unless indicated. Surveillance for high-risk cases like atrophic gastritis and gastric intestinal metaplasia with dysplasia. It's important to know that atrophic gastritis and gastric intestinal metaplasia, when they develop dysplasia, they are high risk to develop cancers. Now, in summary, I will talk about the take-home messages of this talk today. Proper diagnosis of gastritis is important, and its treatment is mainly in treating its underlying causative factor. So if you have H. pylori gastritis, we have to treat the H. pylori gastritis. If it's autoimmune, we'll treat autoimmune. Basically, if it's chemical induced, we advise to patients to avoid alcohol, avoid all the etiological factors, even like smoking. And if it's bowel reflux, we have to treat the bowel reflux. Now, and more so, not prolonged, unprecedented usage of PPIs. And we have to maintain high index of suspicion. And more importantly, we have to know the differential diagnosis of gastritis and not missing important differentials. And consider role of GI lab as to rule out functional disorders, and it enables us to differentiate between them. Also, it's important to acknowledge that chronic PPI usage has various side effects, and even if the risks are low, but we should know of the side effects. Now, PPI use should be of short duration and lower doses. And more importantly, always review our prescriptions for PPI. And next slides, I've finished my presentations. These are my references. And I thank you all for the patient listening.
Thanks, Dr. Sou, for giving us such a concise idea of how to manage gastritis, and also a brief idea of usage of PPI. There are questions popping up for regarding usage of PPI. I think this is one of the most common or commonest drugs that we prescribe every day, day in, day out in our clinic. And also thanks for sharing your experience in managing gastritis with us. So now we will pass the camera to our sponsor for them to show us a video of their product. Okay, hi, welcome back. I think now it is our Q&A sessions, and I think we do receive a lot of questions, and I think we are blasted with questions asking about PPI.
Yes.
Okay, yeah, so I would just I think PPI is definitely being used rampantly in our daily practice. So I'll probably ask Dr. Sou to answer some of the questions, I think, to clear our doubts. So one of the commonest questions that we got is actually, what do you mean by a long-term PPI? And can you help us to clear the participants' doubts on these questions, Sou?
Yes, basically, it's depending on the cause. Again, what is the cause of the diagnosis? Let's say if we are treating for peptic ulcer disease, the cause can be within 2 to 6 weeks, as long as to treat the duration of the to let the ulcer heal, and we reassess back with endoscopy. But let's say we are treating for Barrett's esophagus, then that will be up to 3 months. It's all depending on the underlying causative factor of what are we addressing. So guidelines are shown, but the duration will be depending on the etiology or what are we treating for. But for a lot of PPI usage, some can go all the way to lifelong or even more than 3 months. Again, it depends on the underlying causative factor and the risk, the risk and benefit of giving the PPIs.
Okay, and there's a question actually asking about role of PPI in long-term surgery usage for those actually with ischemic heart disease, with the risk of actually developing ulcer bleeding. What is your view on this?
My view on that would be, let's say, if patient have long-term PPI as prophylaxis in patients with cardiovascular diseases, it depends on the risk of bleeding, because when we give PPIs, along with antiplatelet therapy, we have to ascertain convincingly that we have ascertain that there's no risk of bleeding. Then we can go for a longer duration, where it can be up to 6 months or even lifelong, depending on the risk of bleeding. But we have to do an endoscopy well beforehand, and then to rule out any peptic ulcer disease and bleeding ulcers. But there are various, I think the issues when all these journals highlight is basically when you give clopidogrel and also let's say Plavix with PPIs, due to the competitive inhibition of hepatic enzymes, CYP219, it actually causes the studies have shown that it reduces the efficacy. However, these studies are not convincingly giving adequate evidence.
Okay. So for gastritis, right, do you routinely do an endoscopy for them if a patient present to you actually with epigastric pain?
Okay. First, we have to rule out any alarming symptoms, upper GI related alarming symptoms, and also we would preferably we will do a diagnosis. We do an endoscopy to rule out gastritis, because the studies have showed that the underlying diagnosis is we have to ascertain the causative factor of gastritis. So I would do a routine endoscopy in this manner.
And there's a question actually, from the participant. If you are from a rural area where actually there's no endoscopy service, how do you actually tackle this patient with gastritis?
Okay. Of course, we have to initiate treatment for we can initiate PPI treatments for short duration of maybe 2 to 4 weeks. But however, the patient will warrant a referral to areas whereby, larger hospitals with endoscopy services.
Do you usually stop PPI before your endoscopy?
This is a question that is very interesting, and I get asked about this question. According to international guidelines, they say yes, we have to stop our PPIs for at least 2 weeks before we can proceed with endoscopy.
And just how you mentioned about GI lab, when do you think actually GI lab should come into play? When do you actually think you should actually refer the patient for manometry and actually pH study? After how long after your treatment?
Yeah, this is a very good question. Actually, we have to identify, again, it goes back to the history and the presenting complaint of the patient. If we know that the patient does not present with atypical symptoms of reflux disease, or then we will not, we will need to order a manometry to actually see, to rule out motility disorders. More so, also 24-hour pH studies. see that to ascertain whether this side of is it the reflux, is it a acid reflux, or I'm sorry, is it a pathological reflux or a physiological reflux for that matter. Yeah. So again, it boils out to the underlying the symptoms that the patient present with, whether is it atypical symptoms or is typical symptoms. Good.
I think for PPIs or gastritis, I mean, um, a lot of us after we scope, I mean, scope we can usually control, and if the patient do have epigastric pain, most of the time it is the durations of the scope or the interval to the scope. This is something that we can control. If the patient has any red flag sign or any older age group, I think we should definitely scope them. Whether PPI, once we scope, most of the time, or we used to just label the patient as enteral gastritis without any definite biopsy. And the moment we see the patients in the clinic, and then with the previous scope of enteral gastritis, and then we tend to just continue, months and months of a PPI without realizing that it might not be necessary. And I think usually in our clinic also, when it is run by our medical officers or even us, sometimes we did not really ask the symptoms again, or assess the symptoms back, but we just continue. We look at the scope finding enteral gastritis, and we just continue the PPI. So I think one of the point for us to remember, I think after Dr. Sou's talk, is I think you want to remind us of not to continue forever and ever, and then we have to revisit the diagnosis itself. Yeah. So Mr. Lim, do you have this kind of issues in your private practice, the prolonged use of PPI, or sometimes the patient would just think that this is some magic drugs for them?
Yes, I think actually, it happened actually more in the private practice actually when you see a lot of patients, actually they are already on long-term PPI. Some of them actually even for 10 years, they actually have been continuously taking PPI, and they come to you, they expect actually, you continue prescribing them with PPI. And fair enough, actually, some of them actually, they just refuse to listen to you and they just walk away because you're not prescribing them actually the magic drug actually in which actually they think that can solve their problems. So I think come back to the basic is actually some of these actually patients for my practice, actually they are not really suffering from gastritis. So like Dr. Sou actually mentioned earlier, some of these actually are functional pain, or actually some of these actually patient maybe actually suffer from probably psychiatry disorder, anxiety disorder. So for me in the private practice, if I actually see them actually the symptoms actually are not correlating well with the endoscopy finding, manometry, or actually pH study, I'll actually refer them to the psychiatry for further assessment.
So, Dr. Sou, maybe I'll ask you another question, which is posted by our participants. What is your opinions of managing atrophic gastritis? It's not, it's not acute gastritis, but chronic atrophic gastritis. Do you have? Sometimes we do scopes and biopsy and came out to be the atrophic gastritis. Can you share with us about, some idea?
Yeah. Atrophic gastritis is what we usually do in our treatment will be to limit the treatment of PPIs, and because atrophic gastritis it can cause a lead to gastric cancer and intestinal the sequence of events that will lead to it will be intestinal metaplasia and proceed with dysplasia and go on to lead to cancers. Now, the risk studies have shown that the risk is about 0.1% for atrophic gastritis, and then for intestinal metaplasia, the risk goes up to about 0.25%, and mild and moderate dysplasia it will go up to about 0.6%, and for severe dysplasia it goes up to about 6%. Now, these evidences actually say that when you have chronic gastritis, how do we manage? We do not, we need to follow, these are high-risk patients where we need to follow them up. But do we do a routine surveillance? Actually, it depends on whether the biopsy finding, the histology finding of intestinal metaplasia, and this metaplasia, is it related to atrophic? Sorry, is it is it associated with dysplasia, mild or moderate dysplasia? If it's moderate dysplasia, we will actually survey them about a year with an endoscopy. And if it's mild dysplasia, we will survey, I'm sorry, if it's severe dysplasia, we will survey them 6 monthly with and of course, keep in mind the presenting complaint of the patient. Yeah.
All right. Okay, thanks. I think atrophic gastritis, definitely there's a risk of, progressing to intestinal metaplasia and then subsequent dysplasia. This is what we know as chorea cascade. But again, I think a lot of us sometimes, once we see atrophic gastritis, what I would do, I'll probably really do a proper gastric mapping by doing, necessary biopsies on a 5-quadrant at least. And if there's extensive atrophic gastritis or even intestinal metaplasia, I'll probably watch the patients a bit closer. Different guidelines say different things. I think the European guidelines say, if you have extensive atrophic gastritis or intestinal metaplasia, probably you should do the scope every 3 years. But for countries with higher incidence of gastric cancer, like Korea, Chinese, or Japan, I think their local paper did show that they will probably follow up the patients or do the scope in an annual fashions rather than 3 yearly. I think it is like a risk factor for us. For me, generally, I don't really do them yearly, but I think reading the newer paper produced by the Chinese paper or Japanese paper, now I probably would start doing more often scope for them, because previously when I follow European guideline, I tend to just this is just benign, this is just it is something that I don't need to do scope so often. But I think nowadays I would probably start to change my practice, looking at the newer paper that I've just read from for those Chinese data and Japanese data.
Yeah, I think in my private practice also, actually I changed the practice. I recently also have a case, because actually of this intestinal metaplasia, so we follow her up actually longer. So recently, it turned out to be cancer. So I suppose I think the evidence is there. I think we just actually have to tell our patient the importance of actually following up, and also the importance of surveillance in these kind of cases. I'm not sure Ms. Tee and Mr. Sou, how about besides PPI, do you use other actually medication like antihistamine in your practice?
So probably, I mean, Mr. Sou, you want to just comment that first?
No, we don't use a lot of histamines in practice. We don't use a lot. Yeah.
I think for H2 antagonists, it is not wrong to prescribe sometimes, but again, I think when we use all these drugs, which it's very effective, and I think we really need to look at the indications, not just the choices of medications. Patient receive H2 receptor antagonist and it doesn't work. I just escalate to PPI and PPI forever and ever, and change from different type of PPI. I think nowadays, I mean, when I was a bit younger, maybe I would just give them PPI for a long time. But now that more data have shown that we really have to start prescribing them, I think this is a good idea. If we look at Canadian, some of their guideline or algorithm, they start to prescribe them, use the lowest most dose which is effective, rather than just giving them and prescribe them forever and ever. I think gastritis, long-term PPI, I don't think it is needed. So we need to look into the indications, for those that reflux diseases, and in what Dr. Sou have mentioned of some of the indications. So I don't think for gastritis itself, we need to prescribe a long-term PPI. That is for sure. We need to look into the causes of the gastritis, and stop the PPI. I just feel that, you know, we should start try to resist our hand from prescribing PPI for a lot of patients, because a lot of them really doesn't need it. Yeah, I think probably a lot of questions are not so much of a gastritis, but it's more on the PPI itself. Probably Dr. Sou can tell us why you put as your topic as a, you know, gastritis, a common stomach flu in Malaysia. Is there any correlations that you want to tell us?
Because any message you want to tell?
Because I think the take-home message should be like, we should not, first of all, should not misdiagnose gastritis and mislabel gastritis, and then leading to a stigmata to all our patients. They will be so fixed, have a fixed mind of I have gastritis, and they come in, they are so fixed about that, and and more so even clinicians per se, we are always they tend to overdiagnose gastritis because they are all common conditions. And like the common flu, which the treatment is just of symptomatic treatment, which is self-resolving, and this should not bring for PPIs. We should not prescribe PPIs as if it is the magic drug, and that it is for all cases of gastritis, all cases of epigastric pain, or functional dyspepsia. These are pain. We should avoid that. Because although, of course, there are various evidences to say there are adverse effects related.
One of the common causes actually for gastritis is actually, in Asia Pacific here, is actually Helicobacter pylori. So in your practice, do you routinely actually treat those patients actually with serology positive?
Yes, I'll actually do a scope first, not the serology positive ones. I'll actually again ascertain the symptoms, and then do a proper scope endoscopy, and like how Misty talked about, we do a proper gastric mapping, and then take biopsies to prove that it's Helicobacter pylori. But if then we initiate treatment for the patient.
How long after treatment do you repeat actually a urea breath test for these patients?
It can be done like as early as 2 months or 6 weeks to 2 months upon cessation of the treatment of 2 weeks.
Yes, I think it's very important that actually before you do a urea breath test, patient need to be off of PPI at least for 2 weeks. Yeah.
I think there's a quite an interesting question. So I think this is why exactly Dr. Sou present on this topic, this gastritis topic, because it's not just focusing on gastritis itself. So we have a participant who asked, what is the difference between gastroesophageal reflux disease with gastritis, and can we differentiate them both by just the presenting symptoms? What do you think, Dr. Sou?
Okay. Of course, gastroesophageal reflux disease, from the history, upfront history, we have to talk about the symptoms. Is it typical symptoms of functional dyspepsia? Like they will have typical symptoms like regurgitation, retrosternal heartburn. So these are all typical symptoms. So if they have typical symptoms, I would err more towards reflux disease, but even so, we will subject the patient to a proper pH studies and to ascertain whether it's a physiological reflux or is a pathological reflux.
Okay. I think there's more questions actually. Probably some of them actually. If you miss the question, I think we'll answer you later through email. Okay.
Yeah, so, that's right.
Yeah, I think one of the purpose actually putting up actually this grand round also is actually probably want to show actually to the younger doctors actually how's the trainings like actually in upper GI surgery. So maybe Dr. Sou, maybe you can share with everyone actually how is your training like? Actually, you know, in upper GI surgery so far.
Yes, it's the program. It takes 3 years, and I'm currently in my second year training right now. We get a lot of exposure. That's why we get a lot of cases like this motility cases, benign cases. We get a lot of cancer cases also, and like benign cases like achalasia and all. It's actually I feel is underdiagnosed in our Malaysian society. Now, therefore, the purpose of, the importance of, I want to highlight the importance of GI lab in this case, doing pH impedance, pH impedance, and also esophageal manometry. Now, well, being now in IKN, we get referrals from a lot of areas around the whole East Malaysia. Now, another top reason why I want to talk about this training is that I get a lot of referrals that they misdiagnose, that they're prolonged, they are being treated by various other doctors in the private, maybe in the private or government sector, but they are often treated with as prolonged gastritis. Underlying cause, they miss out tumors. So, which is very sad, and patients come to us with stage 3, and some even like those 2 stage 4 cancers today. So these are the highlight of the talk today. We should know the underlying causes and not label all the upper abdominal discomfort, dyspeptic pain as gastritis, and miss out more alarming symptoms like cancer. That's the
Yeah. So I think it's almost coming to the end of the sessions. As Dr. Lim mentions, for those that we are unable to answer in this platform, then we will actually email you personally so that you will get some answer from us because we really have not enough time to answer all the questions. So Dr. Sou, do you want to make a last closing remark before I give a bit of a housekeeping rule, and then yeah.
I think to thank the organizers and also thank the audiences for patient listening.
And Mr. Lim, do you want to just give us a word on gastritis or the PPI usage, and then any reminders or any advice for all of us?
I think Sue actually had Dr. Sue had already mentioned actually in lengthy actually about PPI and also gastritis. I think with the short of times, I think probably we'll move on to the I hope actually all of you actually will join us in actually next week sessions on actually recalcitrant gastric ulcer when surgery is indicated.
Yeah. So before we end, and do join us next week. And I think for all the participants, you will receive an email for the feedback form. Please fill in the feedback form. And if you have any questions for the sponsors today, just leave your contact and we will get the product representative to contact you. And this activity, it's you can actually claim points under NSR or MyCPD, and the 1E certificate will be sent to you depending on the activities or depending on the series that you joined us. So please join us again next week, same time, for series number 4, recalcitrant gastric ulcer. Thank you very much, everyone, and have a good night.
Good night.
Thank you very much.